Hi, my name is Andy Kaytes, and I'm here with Dr. Susan Swindells from the University of Nebraska, which is something that we can't detect from your accent.
True.
You're not originally from Nebraska.
No, originally from England, but I've lived there since 1991.
Excellent, excellent. Well, I know you do great work there, and we're here to talk about tuberculosis, and that's something that, even though our audience is worldwide, most of them are here in the United States, and a lot of people in the U.S. don't really know much about tuberculosis. So could you maybe give us a little 101 about what TB is?
Sure. So it's caused by a bacteria that's spread by in the air by people coughing on each other. So it's quite transmissible if you're in close contact with somebody. It's been around for a very long time. And in the outside the U.S., as you mentioned, in the U.S. we've done a good job of getting in control of TB. We still have some cases, but because of availability of a good public health infrastructure and diagnosis and treatment, we don't have much. But the rest of the world has huge problems with TB, and in fact, almost 1/4 of the world's population is infected with TB.
Wow.
Which is billions, between 2 and 3 billion people. So just being infected with it, though, doesn't necessarily mean you're going to get sick. Only some people that get the infection go on to get disease. But amongst those are people that have HIV. Because of their immune system problems, they're 10 times more likely to develop TB disease after they get infected.
Interesting. Okay, so it's been around for a long time, and there still is problems with effective treatment and how long the treatment lasts.
So the treatment actually works reasonably well. You have to take a lot of medicine. You have to take 4 medicines for 2 months, and then 2 of them for another 4 months. So it's a minimum 6-month course of multiple pills. It's not ideal, but it does work.
Yeah.
So the problem is really getting everybody that is ill with TB, getting them diagnosed promptly and onto the treatment before they spread it to somebody else, and then keeping them on it for the full course so that they don't go off and develop drug resistance, which is a whole other.
And I imagine that's quite a challenge to keep someone on the medication for that long.
Yeah. Yes.
Wow.
Yes, and talking about doing this in settings where they don't have the kind of public health infrastructure that we have here, and people are, mobile. Sometimes they have to move because of work. Sometimes they have to move because of war and famine and just all kinds of other things that make it difficult to keep track of people and keep them in care, because it's a disease of poor people, like very poor people.
Okay. And there's an acronym that DOT that I like to think of as the Department of Transportation, but that's not what that is.
No, it stands for Directly Observed Therapy. So what the World Health Organization recommends is for everyone who has TB that their local TB program provide this DOT. So they get a DOT worker who makes sure they take their medicine every time.
So that's daily.
Well, it doesn't actually, not always daily. Sometimes
Okay.
it's twice a week, and they don't necessarily do it on weekends. But it's close. It can be.
That's a lot of
as
work.
much as daily. Yes, indeed. Yeah, it is.
Is that going to be the way of the future? Is there anything coming down the road that might be better for that? Make it easier?
Nice of you to ask that, but as you know, that we are working on trying to develop long-acting formulations of TB drugs where an injection or 2 would last for a month, perhaps even 2 months if we're lucky, and then people won't have to have this DOT in between. They would just have to come to a clinic and get their injections, and then they'd be good to go.
Wow, that would be a lot more convenient.
It'd be fabulous if we can get it to work, yes.
Is there a way that you can prevent TB other than, not being in a room with a bunch of sick, coughing people with tuberculosis? Is there prevention?
Yes, so there are several approved regimens of taking oral medicines once you become infected to prevent you getting TB disease. And so the regimens go from 3 months, most of them are 9 months, and then some as long as 36 months. But there are pills you can take every day to prevent you getting TB after you get infected with it.
I know it's virus versus bacteria, but that's sounding a little bit like herpes, that you get it, and if you protect yourself with medication, like valcyclovir or something like that, you don't get the outbreaks. And it just kind of stays under control. So
it's sort of like that, but the important difference with TB is if you take this preventive treatment, it cures you.
Oh.
So it's not like herpes, which, as you know, is the gift that keeps on giving,
Yes.
because it will come back.
Yes.
If you complete this course of preventive treatment, then the TB is gone from your body and you're cured.
So much better than herpes.
Yes, so much better. But you can get, it doesn't protect you from being re-exposed. So someone else comes and coughs on you on the bus, then you're back to square one. But it does get rid of the infection that you had.
Wow. It sounds like a big challenge. And then there's the drug-resistant varieties. Yes?
Correct, yes.
And that makes it even harder to medicate against.
So yes, then you're talking a minimum of 9 months of treatment, including a daily injection, which is really pretty awful. I mean, a lot of pills, and it's not fun, and sometimes even longer. So getting drug-resistant TB is pretty miserable.
Wow. And I understand there's also interactions with HIV drugs and tuberculosis drugs.
Yes.
So
yes.
You can't just prescribe willy-nilly.
Exactly. Yeah, no, that's an excellent point. You have to be very careful about that because you can make people quite ill. But I think it's important that people understand, ideally, you do want to treat both things together. You don't want to not treat someone's HIV, and you certainly don't want to not treat their TB, and it is possible, but you just have to be careful and mindful, and if necessary, consult an expert or, go somewhere where you can be sure that the regimens you're using for both are compatible. But it's a challenge, you're right.
It sounds like not something you'll get at the Minute Clinic. Wow.
No, don't go there.
Very complicated. Well, so that said, here we are at CROI, and I'm sure there's been some interesting presentations regarding tuberculosis, and
Lots of good stuff.
What would you like to tell us about that?
Well, the most important thing, I think, because I'm co-chair of the study, is that we now know that in people with HIV, that taking this preventive treatment for just 1 month works as well as the 9-month regimen. So that's a real game changer. Just found out yesterday that was presented. Yeah.
Wow, that is a game changer.
Yeah. So if you only have to do it for a month, then that makes it much easier. And so one of the problems with this preventive treatment, because it's so long, people just get fed up and stop taking it. But if you only have to do it for a month, then that's much more feasible. Plus, there's less side effects happen because, it's just a month.
Yeah, that makes good sense. So you say they get tired of taking it, and that's a pretty obvious, reason for the length of time for maybe interrupting or not being as adherent as possible. But what about people who are HIV infected and they take medication every day? Do you find they're more adherent and
not necessarily. We're lucky if we can get 60% of people to finish a treatment course. And the problem really is, Andy, it's because even though they are taking medicine, the HIV medicine they know they absolutely have to take. This one, you tell them you're infected with TB, you might get TB, you might not.
Oh.
Here, take this pill, even though you feel fine. And after a while, they think, I don't know, should I really bother with this? Particularly if they start to develop some kind of side effect, then they just drop it.
And are these medications prone to side effects?
Some, yes. All medicines can, but TB drugs can have side effects. Yes, we really do need better TB drugs. So it's not like HIV where there's been continuous development of new drugs and better and better side effect profiles. That is absolutely not happening in TB at all.
Wow, and TB kills more people than HIV, doesn't it?
Yes. Well, globally, it's the biggest killer of people with HIV.
Wow.
So, yeah.
Wow.
But if you look at the overall numbers, yes, more people die of TB. So it's 1,000 people a day die of TB. Today, 1,000 people will die of TB in the world.
So dozens while we sit here.
Yeah.
Wow. That's scary. That is really scary. So have you seen any other posters or presentations on any other drugs that may be coming down the pike?
There's not a lot in the drug development pipeline. You're not even really a trickle, to be honest. We'd like it to be more. But the other thing that's not ideal about TB is the diagnostics are not great. And so there are some interesting presentations here about improved ways of knowing exactly who has TB quickly and easily, and knowing who would benefit best from this preventive therapy. So there's been some good research on that.
I see, because I understand, it's sputum that you test.
Right.
And for that to happen, you have to grow out a culture, and that takes a lot of time.
Yes.
And
We do have rapid tests we can do on sputum, but even just getting people to produce it, children can't do that, for example.
Oh, yeah.
So that's a thing. And not even all grown-ups can do it. And so it'd be so much easier just have something like the HIV test, which is so easy and quick and practically perfect. Yes, you have it, no, you don't.
Yeah.
Because with the sputum test, even if it's negative, we're still not quite sure. And so we do need better tests.
And what's happened with the gene expert regarding these?
That's
testing?
been a huge advantage. So that has speeded, what you were talking about, this sputum, rather than waiting for the culture. With Gene Expert, you can get an answer in 4 hours.
In 4 hours. That's a huge increase in
huge.
time to play with what medication you need to give somebody.
Right.
And doesn't it also do a little bit of work as far as finding out if it's a drug-resistant strain?
It does indeed. It does.
Wow, that's great.
So that's been a huge help. But again, even if it's negative, you can't absolutely take that to the bank. So
Nothing's perfect, is it?
Not many things. No.
Not many things. Well, let's see. So lastly, I think I'd like you to touch a little on long-acting preparations that may be coming in people's minds, at least.
Yes, well, they're in my
tuberculosis.
mind and in others. And so we're at the very beginning stages. We have this little sort of library, as it were, of TB drugs, and the clever physicists and chemists and pharmacologists that I work with can tell us, which of them would be suitable for a long-acting formulation. For TB, unfortunately, not many of them are, so they will need some tweaking to be able to be made into a medicine that will stay in the body for a week or two, 4 weeks. That's going to be a challenge. But we're working on it, and we hope we'll be able to get there.
Well, that's something we'll all keep our fingers crossed for. And I guess until then, we just wait and see and continue to look at presentations and posters that come along and the research that you do. And when do you anticipate the study you're doing now will show any fruit as far as data?
For the long-acting?
Yes.
Oh, it's a ways off. So we have to make these new formulations of the drugs and then test them in cell systems, and then.
So we're really on the bench in basic
small
science.
Animals. Yes. Yeah. But what is it? Every journey starts with one step of 1,000 miles or something, isn't there? Something?
Yes, that's true.
I've just completely mangled it, but you know what I mean. We're starting the first steps.
Agreed. I think that's sage words of wisdom. So, well, I thank you very much for talking about tuberculosis with us. And before I let you go, is there any other thing that you've seen at the conference that gets you excited?
I think some of this prep stuff is kind of cool, and some of these experiments of trying to get to zero, that some of the cities and countries are doing. That's exciting, don't you think so?
I think it's amazing, and with all of the different things that are coming out as far as PrEP is concerned, you've got implants, you've got injections, you've got all kinds of things being looked at. I think the variety of tools, the more we can have, the better it will fit every person's individual needs. And hopefully these things will pan out and be effective so that we can have more than just one pill for PrEP. And
I agree.
it would be really great if they were long acting.
Yeah, yeah, so much easier.
We'll keep working on it. Well, thank you very much.
Thank
and
you.
Have yourself a wonderful conference.
You too.
Thanks.
Okay.